The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hello, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. This is the next installment in our alphabet series of episodes. I've been thinking a lot about what to do for this D episode. After a constipation episode, the most obvious thing to do next would be a diarrhea episode. But you know what? I don't like that word. I don't like saying that word. I don't like thinking about what that word means. And I don't want to talk about it for 30 to 45 to 55 minutes. So I'm not going to do it. You can figure that shit out on your own. Pun absolutely intended. Someone suggested I do an episode on deprescribing, which I thought was a great idea. I'm sorry I can't remember who that was. If you're listening, please remind me and I'll be happy to credit you on the episode. I like to give credit where credit is due. Somebody else came up with this idea, but I thought it was a great idea. So that's what I'm going to do. Deprescribing. Very important topic. There's so much polypharmacy that happens in medicine. Oh my goodness. You get these people that have to tote around their trash bag literally full of medications. And I think we all know that sometimes medicine can be the big problem, the main problem. And sometimes you recognize that and sometimes you don't. So I think it's good to always keep it in the front of your mind that problems could be due to medications. I did some training with a cardiologist when I was in practitioner school, and he's really big on this. And he gave me a piece of advice that has stuck with me, maybe one of the single most useful pieces of advice that a doctor's ever given me. He said, if something's wrong with the patient and you can't figure out what it is, it's probably their medicine until proven otherwise. And they did a lot of deprescribing in that office, and that really stuck with me. So in my practice, I try to just make it a habit. And I pretty much have, I still overlook something every once in a while, but I pretty much made it a habit to just move my head, turn my eyes to the medication list on the computer screen whenever we're talking about any kind of problem and just look down through there and think, I wonder if any of these medicines could be causing this problem or a combination of these medicines. You know, of course, our EMR has a built-in interaction checker and there's all kinds of different tools you can use for that. But I don't know that anyone really truly can understand how a combination of medicines, especially when you're talking about people who are on a very long, extensive list of medicine. You know, when you have 50 medicines on your medication list, I mean, maybe you need to be on 50 medicines, but I don't know that anyone can truly wrap their head around or have a complete understanding of how all of those medications are working and interacting with each other and causing problems in an individual patient's body. It's a really murky situation. It's a really tricky thing to address. And I'll tell you right up front that I'm not an expert on this. I struggle with this so much. I think a lot of what I'm going to say today is just commiserating more than anything. I don't have the magic answer for this. It's a very hard topic. It's a very hard thing to deal with in medicine. And as fragmented as the healthcare system tends to be, you know, you have multiple specialists all doing their one little part, all looking at their one little part. And sometimes it seems like nobody's paying attention to the big picture. And people get in trouble with this. So I'm just going to talk about my perspective on this, give you my opinions on this. I'll talk about some specific tools that you can use that may be helpful to you, but it's just a tough situation. You know, it seems really straightforward when you're reading about it in school, right? There's this, oh, here's the Beers criteria, and here's the medications you don't use for people when they get elderly. And you think, oh, okay, great. Well, I'm going to go through, you know, day one and take all of the people over 65 off of all these bad medications that are hindering their quality of life, and I'm going to be a great clinician. I think we all start out with the best of intentions that way. Of course, I'm not going to overprescribe medicine. Of course, I'm not going to enable people's drug addiction by prescribing them things that they don't need. Gosh, if only it were that simple. If only it were as simple as it always seems in the textbooks. Everything's a gray area. Everything's super complicated. Every patient is a different situation. And you just have to muddle through it. You just have to figure it out. There's no one right answer for everybody. This comes up in all kinds of different situations, but probably the most stereotypical, the most common situation that you think of with this is the elderly patient who comes in and it sounds like they're falling more. And you look down their medicine list and they're on a handful of medications that could be problematic, right? Whether that's dropping their blood pressure, dropping their heart rate, sedating them, anticholinergic effects, whatever. And you start going, okay, or I think you should start going, okay, which one of these medicines can we go after? But then sometimes it's the patient that's driving this, right? There are a lot of patients who really don't want to take medicine. Many times these are younger, I'm going to go ahead and say more often males, but maybe that's wrong. That's not based on any sort of scientific data. But it seems like a lot of younger men are very much like, I'm not taking statins. I'm not taking blood pressure medicine. I don't like these pill pushers. And definitely you'll have older patients come in who are on a ton of medicine going, I'm tired of taking all these medicines. What can we get rid of? So then it becomes a matter of going through the med list one by one and thinking about risk versus benefit of each individual medication. And unfortunately, more often than not, the patient who comes in saying, I'm tired of taking all these medicines. I need to get off some of these medicines. Once you go through the list one by one, it's like, well, I can't stop that. Well, no, I can't stop that. Well, no, that one helps me. I got to take that. And you end up going, well, I mean, you've never had a heart attack. I guess you could stop the aspirin if you want to. A lot of times, unfortunately, you can't really find anything that stands out. But going back to the first situation where you have elderly patient starting to fall, you want to do everything you can to try to get them off of problematic medications. Sometimes that's doable, and sometimes it's like, you know what, good freaking luck. I mean, if somebody's been taking Xanax for 20 years to control their anxiety and is in terrible pain, and the only thing they can take is an opiate because nobody will do surgery on them and they can't do physical therapy, or they won't do physical therapy, and they have to take their Ambien to sleep or they're going to be miserable. I mean, that's an impossible situation. You're between a rock and a hard place. So really, what is the right thing to do? The textbooks would tell you that you have to stop all that crap. You have to get them off of all these sedating medications because they're going to fall, they're going to break a hip, and it's going to be your fault, and they're going to die. And maybe people practice like that. I don't. I can't. Because I think we should also be thinking about our patients' quality of life. At what point do you say, I'm going to make you less comfortable, I'm going to make you more miserable in the interest of your own safety? It's impossible. It's impossible. How do you make that decision? One of the worst situations that has happened to me my whole career, I would say, or at least has stuck with me as much as anything that's ever happened to me in my whole career, happened pretty soon after I took over my current practice. There was a patient that was on long-term opiate therapy. If I remember correctly, they were on oral oxycodone and topical fentanyl patch. And in our practice, we don't really do pain management so much. We don't mind keeping people on hydrocodone, oxycodone every now and then if they come to us already on it or something like that. But that's pretty much the limit of what we're doing with opiates. We want people to go to pain management if they're really in that much pain that they require multiple opiates and things. But this person, when we inherited them right out of the gate, I knew that we were not going to be comfortable with this. And in Alabama, of course, there's no independent practice for mid-levels. The physician determines the rules for their practice about what they're going to prescribe and not prescribe. And with controlled substances, we mid-levels have to go by that. Not that I want to necessarily be involved in pain management or addiction management, but we're not. That's the doctor I work for's choice, and that's just how it is. That's what I have to work within the parameters of. So I have a conversation with this person, and they're willing to work with me to try to reduce the amount of opiate they're on. Because, of course, you read all this, you're told all this. So many people on long-term opiate therapy probably don't need it in the first place. And you'll read these studies. It's like, and I'm exaggerating here. I'm not citing any specific study, but you'll read these things or hear these things where it's like, oh, we compared, being on placebo or acetaminophen to being on these huge doses of opiates, and it's just as effective. It's like, okay, if you say so. So anyway, we set about trying to get this person off of this regimen. We started with the fentanyl patch. Then we started working on the oxycodone. The goal was to get them down onto a reasonable dose of hydrocodone that we were comfortable with. We went too fast because we are just not comfortable doing we just don't do fentanyl patches, okay? We just don't. And so this person, unfortunately, went away and suffered in silence for weeks. It was a shockingly long time. When I saw them the next time, they were like, yeah, the withdrawals from that were pretty rough. And I was like, oh no, that made me feel terrible. Like, why didn't you call? Maybe we could have done something. Maybe we could have worked something out. But they just kind of suffered through it. And then we tried to back off and get them down onto hydrocodone. Hydrocodone made them itch, as it is wont to do. So now the pain's not controlled. They're going through opiate withdrawal. They're itching like crazy. And then they died. And as far as I know, what we were doing didn't really contribute to their death, but it sure did make them miserable for the last several months of their life. And that has just stuck with me. I feel absolutely terrible about that. I still feel terrible about it. Every time I see that person's family now, I just want to apologize over and over and over. I mean, in hindsight, I wish we would have just left it alone. I wish we would have just not rocked the boat. But at the time, it felt like the right thing to do. At the time, it felt like, oh my God, you're on too much pain medicine. We have to get you off of some of this because what? That's the right thing to do. It's better for you. Okay. Thanks for making my last month absolutely miserable. So was that outcome worth me being able to pat myself on the back and go, oh, you're a good clinician because you're trying to get these people off too much pain medicine? I don't know, man. I don't know. that definitely would have been a person we would have tried to send to pain management. Because as far as I'm concerned, the ideal situation if somebody's going to be on chronic opiate therapy is that it comes from a pain clinic. 'Cause that's their thing. That's what they deal with. That gets any concern off of us that we're enabling or doing too much or whatever. But unfortunately, what I have seen, this is my anecdotal experience, is that you suggest that somebody goes to a pain clinic who's already taking a bunch of pain medicine. They go to the pain clinic, they realize that the pain clinic is not going to immediately start prescribing the opiate they want, and they never go back. So then you're back right where you started, square one. Addiction centers are a good option. I kind of think everybody should be prescribing buprenorphine since the X waiver thing is not a thing anymore, but that's another thing that we don't do. So I do often suggest to people that they go to an addiction treatment center and start doing buprenorphine or one of those similar treatments. People don't like to hear that. People don't like to feel like they're being told they're a drug addict. And if you've ever been to one of those clinics, they can be a little shady. Sometimes they're in kind of sketch locations, and a lot of times the people who are lined up to get their treatments are kind of sketch looking people. So I think there's a pretty big stigma and a lot of resistance for people to go do that. So sometimes it feels like no matter what the situation is, no matter what alternatives we try to offer, the burden of figuring out what to do just ends up right back on us. So what do? It just sucks. The whole thing just sucks. It sucks for everyone. I hear a lot of elderly people say, oh, the medical system won't do anything for you once you get old because they don't care about you anymore. And obviously that's not it from our perspective, or at least from my perspective. It's just the fact that as time goes on, the risks of things outweigh the benefits, right? Yeah, you don't need a colonoscopy anymore because at some point the risk outweighs the benefit. Yeah, you probably can't have massive back surgery at some point in your life because the risk outweighs the benefit. I think we look at it as I'm trying not to kill you or make your life worse. Whereas I think a lot of them look at it as you're not going to do anything to help me because I'm too old. And like it or not, at least part of their thinking is correct. You're right. I am reluctant to do anything because you're so old. Not because I don't care about you, but because I don't want to do anything to cause you harm, right? First, do no harm. So that's just sort of a bad look. And that's the thing you have to overcome sometimes when you're talking to people about what they may or may not be candidates for, or what you may or may not be willing to prescribe for them or order for them or whatever. I've already talked a good bit about opiates. I wanted to kind of focus on that some more. A lot of the issues that happen around deprescribing and going back and forth about whether you should be prescribing something or not revolve around opiates. Sometimes other controlled medicines too, but I think the big class is opiates. Obviously, there's been a big focus on that since we had the whole opiate epidemic, the whole situation with Purdue Pharma and the Sackler family. I think that's a pretty commonly known thing that happened at this point. And now I feel like the pendulum's kind of swinging back too far the other way, where nobody wants to prescribe pain medicine for anything. Actually, just earlier today at church, some of our choir members were talking about how, oh yeah, nobody will treat your pain anymore. And somebody else said, yeah, thanks, government. Nobody will give you pain medicine anymore when you need it. And that is kind of how they make us feel as clinicians. Here in Alabama, for mid-levels, to be able to write any kind of controlled substance, first you have to practice full-time for a year. So right out of school, there's no chance you can do anything like that. Then you have to show up for this 3-day-long class about prescribing controlled substances where it's mostly informational, and then they kind of also scare you into feeling like they're watching you. They have a DEA agent actually come and talk about what it's going to be like when the DEA busts the door down to your office. And then they stand up and say, now, we're not saying you shouldn't write these prescriptions. Okay, some of these patients need these prescriptions. Okay, yeah, that's totally the message I got from the DEA. So after you do that, of course, you have to have the DEA number. You have to get a specific type of license that allows you to prescribe Schedule 3, 4, and 5 medications, and then you apply for a separate license that allows you to prescribe Schedule 2 medications. For those, your collaborating physician has to specify exactly what they want you to be able to prescribe, and that's it. And then we get a report, I think, every quarter from our prescription drug monitoring program that shows us how much are you prescribing controlled substances in comparison to other people in similar practices. There are a lot of very specific rules about this, and rightly so. I'm not saying this should not be regulated. I'm all for it. But yes, and on some level, the powers that be, the government, the medical regulatory agencies, do make us very aware that they're keeping an eye on us. And if you're operating a pill mill, they're going to come shut you down. Again, very appropriate. Does it make me think twice about writing pain medicine for people when they need it? It sure does. That, along with concern for not wanting to hurt the patient. And man, you really get into some tricky situations with this. It seems like there's such a fine line between people who legitimately need to be on pain medication because they're in pain and people who need to be on it because they're addicted to it. And in my mind, at least, being addicted to something or being dependent on something is not necessarily the same as abusing it, right? And you can take an opiate exactly as it's prescribed and never ask for more to keep your chronic pain under control. But once you've been doing that for 5, 10, 20 years, whatever, are you dependent on that medication? Yeah, you probably are. Would it be a bad day if you quit taking that medication abruptly? Yeah, probably would. That's not the same thing as somebody who is using it to feel good, to get high, who's taking more and more and more and more and mixing more and more and more things together and that sort of thing. But at the end of the day, in the strictest technical sense of the term, are you a drug addict if you've been taking an opiate for 20, 30 years? I mean, yeah, right? And all those people kind of get lumped in together, which is not fair, right? It's not fair to people who have chronic pain and take pain medicine and don't abuse it, and it just works and it helps them and they're fine on it. And sometimes it's pretty hard to tell the difference. And sometimes you get in a situation where you understand that you are just treating an addiction and not so much a chronic pain situation. But that's still a problem, right? That's still something that we need to treat. Is it the right thing to do to cut some people off because you think they're addicted or because you think they're abusing it? Well, yeah, by the textbook, it is the right thing to do. But throwing somebody into withdrawals and making them miserable and blah, 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 is that really going to solve the problem in the long term? I don't know. I don't know. It just has to be a case by case basis. And I think you just have to feel it. That's the conclusion that I've come to after dealing with some of these situations. I think you just have to, at the end of the day, go with your gut and do what you think is the right thing in a given situation. I try to err on the side of trusting my patients, believing my patients, helping my patients. If somebody comes in once in a while and says, hey, I'm going out of town, I need to fill this prescription a little early, or hey, I fell and hurt my arm, so I've been taking more pain medicine than usual, I try to help them out. It's amazing how many situations some of these pain medicine people get into. It's amazing how many vacations some of these people go on. It's amazing how often they just need a few extra. And I don't let that go on forever. We have fired some patients who started that cycle of give me a little more, give me a little more, give me a little more. Okay, I was born in the dark, but it wasn't last night. At some point, we draw a line and say, okay, no more. When I was going through my initial controlled substances training that I had to do, one of the state medical board doctor people who was one of the speakers said a comment that has stuck with me. He said, if you can't say no, then you shouldn't say yes. As in, if you can't stop this and cut it off, then you shouldn't start it in the first place. And I think about that a lot in these situations. And very honestly, I do have trouble saying no. Like I said a minute ago, I want to believe my patients. I want to trust my patients. I want to have that good rapport and not feel like I have to do drug testing and pill counts and pain medicine contracts and all that stuff. Which if you're doing pain management, I mean, if you're really doing pain management, then yeah, you have to do all that stuff. In our situation, it's more of a closed system. We've known these people forever. We see a pretty stable patient population. We just kind of know these folks, so we don't usually resort to that sort of thing. But every once in a while, it just does get way out of hand. I had to say no recently. I had a patient who was taking a bunch of pain medicine and lying about it. They have a legit condition that was causing chronic pain. They were giving me the impression that they were weaning down, that they were on the way to getting off of it, that now I'm not using it very often, that sort of thing. But checking their PDMP, the Prescription Drug Monitoring Program report, made it obvious that they were filling a crap ton of opiates, like right on schedule, getting it from multiple providers for multiple reasons, that kind of crap. And it was just so far over the line that I had to grow a backbone and say, no, I'm not comfortable doing this for you anymore. I'm sorry, that's it. And in that situation, it wasn't so much the pain medicine as it was the lying. I've always appreciated when patients will just come out and say, yeah, I'm abusing this. Yeah, I'm addicted to this. Yeah, I've been taking too much. I think if we start with the truth, then we can work together to create a reasonable way to deal with the situation and we can still trust each other. But if you're lying to me, that's over the line. I kind of thought that patient would never come back after we had that conversation, but they have, which makes me feel good. But yeah, pain medicine, I can understand definitely why some places and some clinicians just don't do it. Just say, nope, no pain medicine. And that so sucks for the people who legitimately need it and do fine with it and it doesn't cause a problem. It's like one bad apple ruining the whole bunch, right? But man, it's such a fine line and man, it really does get out of control sometimes. It's a blessing and a curse, the pain medicine. Of course, there are a lot of other reasons to deprescribe and a lot of other medications that can be problematic. Pretty much anything that can cause somebody to be oversedated can be super problematic. I'll tell you about another situation that I dealt with. This is a patient that is a special needs kind of person. And without getting too specific, they have a lot of chronic issues that they just have to be on medication that can be problematic. Like it's just not optional. And one of their issues is behavioral. Like they can be pretty hard to control. They're pretty wild. They live in a facility. And I'm really big on protecting my colleagues, my coworkers, staff members that have to take care of people directly all the time. I don't think working in healthcare should mean that you have to be attacked or that you have to physically fight with people. And sometimes we do. That just comes with the territory, I guess. But I don't think that should be an expected part of your job. It used to drive me absolutely nuts in the hospital and see these situations, not so much in units I worked in, but like on med surge floors and places like that, where you had these people who were just uncontrollable for whatever reason, whether it was a altered mental status situation or they're intentionally being terrible or whatever. And the nurses couldn't talk the doctors into ordering anything to sedate him. Well, we can't sedate him. Well, you shouldn't, we've got to be careful. We can't sedate these people. And you want to be like, well, you come up here and fight them for the next 12 hours. How are the, 4 or 5 people staffing this entire unit supposed to control this uncontrollable patient with no medication help and take care of these other 60 patients that we're trying to deal with, whatever? Like, it's really just not fair all the way around. I guess about the only situations like that I had to deal with in PICU were when you had the patient who has been intubated for a while and we're weaning off sedation, and you always work nights, so you come in for the night shift and they're like, okay, so we've started weaning off the sedation and they'll get extubated in the morning. Ooh, that is a setup. That's a setup. One of my favorite nurses that I used to work with would say that all the time. This is a setup. She'd give you the side eye. I go, this is a setup. And that was another situation where you wanted to just like go to the doctor's house and bang on their window and be like, hey, do you want this tube to stay in its trachea or not? Now I'm spending my whole shift trying to fight this child to keep them intubated without hurting them. Such a bad situation. But that always has stuck with me. And so anytime it's up to me, anytime I'm in charge of that sort of thing, I'm going to do everything I can to protect staff members from patients. And if that means writing an overly sedating medication to somebody that really you wouldn't want to, I'm sorry. That's just what it has to be. And so with this particular patient, they kind of went downhill to the point where they came in essentially unresponsive. And the general thought was, well, they're pretty elderly. They have all these chronic problems. Maybe they're just about to die. Maybe that's just what's happening. So we even had that talk, and we said, okay, we need to start pulling off some of these medicines, not necessarily because I thought it was the medicine causing the problem, but because I thought we were kind of entering a palliative hospice kind of territory. So we start pulling off medicines, and lo and behold, the patient comes right on back to life. And now they're their old self again. They're vibrant up, running around. We're overdoing it with the combination of medicines that they had to be on and the combination that it seems like they needed to be on to keep them under control. We just overdid it. And I'm forever grateful that we got some of those medicines off before the patient actually died, because I think they would have. So you got to be careful. You do. That's a great example of why this is so important. Okay, so how about some specific tools that we can use to help us with this deprescribing endeavor? I think we all know about the Beers criteria. This is just a list of potentially inappropriate medications. Spoiler alert, there's a lot of medications on it, and a lot of really common medications. And that's what I always run into when I'm thinking about these situations. Like, yes, these elderly people shouldn't be on these medications. Guess who needs these medications, really? The elderly people who don't need to be on them. It's a circle. It's a loop of logic that you will just get stuck in. And that is a dynamic thing, of course. They add to it all the time, so not a bad idea to review that now and then. There's a tool called the Stop-Start criteria. That stands for Screening Tool of Older Person's Perceptions / Screening Tool to Alert to Right Treatment. There's an organization called Deprescribing.org. I went to a class where they pointed us toward this resource. I keep these algorithms on my desktop computer at work. I don't know how much I've ever really actually referred to them in practice, but pretty cool resource to give you some structure if you're needing to go about undertaking a complicated deprescribing situation. There's a tool called MedStopper that you can put a patient's medications into, and it'll kind of rate each one based on its benefit and harm in older folks. It'll suggest alternatives for you and give you some guidance on how to taper off specific medicines. There's one called the No Tears tool. That's an acronym for Need and Indication, Open Questions, Tests and Monitoring, Evidence and Guidelines, Adverse Events, Risk Reduction, and Simplification. From the United Kingdom, there are NICE guidelines. It took me a while to figure out what NICE means when it shows up in the literature, or I've been listening to a podcast sometimes called Primary Care Knowledge Boost that's made in the UK. NICE stands for National Institute for Health and Care Excellence. I think it's just their version kind of the NIH. It's an independent agency that has guidelines on things. So they have some specific guidelines on that. And then there are these things called Empower brochures, and those are designed for patients to look at to help them kind of think about questions they should ask or inappropriate medications that they may be on that they could think about getting off of. I'll put links to all these different tools for you in the show notes. I'm just going to be very honest and say that I have not used any of those really. again, in my clinical experience, it just kind of comes down to each individual situation and how you communicate with an individual patient and the rapport you have and the family members that are around, and just every little detail about the situation matters. So it's a hard thing. I guess I'm going to end saying the same thing that I began with. It's a hard situation. I feel defeated by these situations a lot. Even just talking about this whole topic makes me feel a little defeated. It's just all about balance. It's all about risk versus benefit, desirable effects of medications and adverse effects of medications. And I don't know what else to say, man. Good luck. I appreciate you listening this week. Special thanks to our Patreon supporters. If you have any tricks or resources or things that you found to help in these situations, please, by all means, get in touch and let me know about it. I'll be glad to pass that on to all the rest of the listeners. On a completely separate note, just on a state of the podcast kind of note, I'm kicking around the idea of trying to rebrand, maybe come up with a more attractive name for the show, or I don't know. I'm just doing this as a hobby at this point, but this has just never taken off. The number of listeners has been very static for a long time. I don't know if that's just because it's not very popular. I don't know if I just suck, or if I'm not unlocking the keys to the different algorithms that promote these things or whatever. I don't know. I never set out to make a career out of this, but it would be nice to see the numbers steadily going up. It would be nice to actually make some money from doing this someday. And man, I see all these creators, especially on YouTube. I've been on YouTube a lot lately, just trying to get ideas for how people run their channels. And there's so much stuff out there that you're just like, why would anyone care about this? And they're like wildly popular, making tons of money off of their weird stuff that you wouldn't think anybody would care about. So I don't know what I'm doing wrong. I don't know if I'm doing anything wrong. I don't know. If you have any suggestions for me, let me know. I don't have a ton of time to put into this, and it's hard to justify putting a lot of time and resources into something that is for sure not making me any money. But I don't know. I'm open to suggestions. All right, that's it. I'm going to quit talking. Have a great week. I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic, or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients, in that order.